Welcome to the virtual Melanoma Summit sponsored by Johns Hopkins University School of Medicine at Oncology Care Live. My name is Dr. William Sharfman and I'm the Director of Cutaneous Oncology at Johns Hopkins Oncology Center. You are tuned into a live session called Surgical Management of Melanoma, involving practices of Dr. Julie Lange. This session kicks off our 2013 Melanoma Summit, New Frontiers in Melanoma Management. I'm excited to chair this live online program for the second time. Today's program will cover surgical management, targeted therapies, and immunotherapy in the management of melanoma and feature respected faculty from Johns Hopkins University School of Medicine and the MD Anderson Cancer Center. Dr. Lange is Associate Professor of Surgery and Dermatology at the Johns Hopkins University School of Medicine and has a clinical focus on care of melanoma and breast cancer patients. She was one of the original members of the melanoma group at Hopkins when it was first formed in 1995 and now serves as the clinical co-director of the melanoma program. Before I get started, we'd like to remind our audience that we'll be taking questions in real time throughout this presentation. You can send in questions anytime during the program through the box in the lower left-hand side of your screen. Dr. Lange.
Good afternoon. Thank you for joining us today. Today I'll be talking about one of my favorite topics. It's the surgical management of melanoma, and in particular, we'll be focusing on some issues regarding management of the regional node basin. I have no disclosures. So melanoma has been largely a surgical disease. 100 years ago, it was almost exclusively a surgical disease, and today, while we have new and evolving therapies for melanoma, the majority of melanoma patients are treated surgically at one time or another. And one of the most important areas of controversy is the regional lymph node basin. So one thing we know about the lymphatics and the skin started back in the 1980s. Dr. Sappi was a French anatomist, and he injected mercury into the skin of cadavers because he wanted to find out what the cutaneous lymphatic circulation was. And he determined that it was very predictable. He drew some lovely diagrams showing that you could predict pretty clearly where the lymphatic circulation was going to go, that it would seldom cross the midline of the torso, that it would seldom cross a line around the midpoint of the torso. And we now know that it's a little bit more complicated than that. One of the first surgeons to talk about the regional node basin was Herbert Snow. And Herbert Snow was a surgeon who in London in 1892 gave a lecture about melanotic cancerous disease, by which of course he meant melanoma. And in particular, he pointed out quite clearly that there were two particular points of interest about melanoma. One is that the primary site was usually quite small, and two was that it was fairly common for melanoma to involve the nearby lymph nodes rather early in its course of disease. And he felt that it was utterly futile to address the primary site only, and that it was very important to take control of the regional node basin before they became enlarged. And he said that you should never overlook doing that. You should never neglect to do that. And so basically what he is describing is the elective lymph node dissection, that is, removing the lymph nodes in the regional node basin even when they're not enlarged. And that was the first, I think, clear description of the elective lymph node dissection, which then became debated for about a century after that. A subsequent colleague of his, Dr. Handley, also talked about melanoma and gave a lecture in the early part of the 20th century in London about the pathology and the surgical management of melanoma. And he once again felt it was imperative that you remove the nearby regional nodes as part of the initial operation and not to wait for them to become enlarged. And so therefore the elective lymph node dissection became a very common part of the initial surgical treatment for much of the 20th century. But then things changed. A number of studies were then done to look at the potential benefit of the elective lymph node dissection. Some retrospective studies suggested a survival benefit. A number of prospective randomized trials, however, did not show a clear overall survival benefit, and the elective lymph node dissection became less commonly used towards the end of the 20th century. And it was eventually supplanted by the sentinel node biopsy in the 1990s. Dr. Morton introduced the sentinel node biopsy for melanoma patients and described it in great detail in the early 1990s. And throughout the 90s, it became very rapidly generalized and came into common use for the staging of patients with early melanoma. So today we still worry about the regional nodes. We think about them a little bit differently than surgeons did 100 years ago, but we've come to wonder, in an era of emerging targeted therapies and newer immunotherapies, does it really still matter what we're doing with the regional nodes? I think the answer is yes, but we'll talk about why that is. So in 2011, a variety of new drugs were approved for melanoma, including PEG interferon, ipilimumab, vemurafenib, and all of that is good news for melanoma, but still really none of that applies to patients who are at their initial diagnosis. None of them have really solved the problem of treating melanoma overall. And so I'll take a look next at why we're still so focused on the regional node basin. And this is a very simple figure that looks at survival for patients with positive nodes. And the main reason that this was published was to look at the differential survival for patients with different numbers of positive nodes. And so on this survival chart, you can notice that the uppermost curve is for patients with a single positive node. And you can notice that over time, initially some patients will die of their disease, but over time the curve seems to flatten out. And if you look out beyond 10 years or so, somewhere in the neighborhood of about 40% of those patients may still be alive, even having been treated for a single positive node. With increasing numbers of positive nodes, the overall survival gets worse. But there are two other things that are really important to notice about this figure. So one of them is that when you look at the shape of the curve, among the node positive group, if patients are going to die of their disease, they usually do so fairly early. Most of the patients who end up recurring from melanoma will do so in the first 2 or 3 years after management of their regional node basin. So that's one important thing to know. The other important thing is to look at the long-term follow-up. This curve follows patients out to about as much as 15 years. And if you look at the curves out beyond 10 years, the curves have flattened out. They're not exactly flat, but there are very few patients dying of their disease out past 10 years. So they're an interesting group of patients because we know they're a high-risk group of patients, and also a substantial minority of these patients actually have the potential to do quite well in the long run. Another group that looked at the same topic looked at the long-term follow-up of over 2,500 node-positive patients, and this is information from a study from Duke University. And within this study, they reported a median survival of 3.4 years. They noted that the overall survival and disease-free survival appeared to plateau out at 20 years. More importantly, of the deaths that occurred less than 10 years out, more than 90% of them appeared to be attributable to melanoma. On the other hand, of the deaths that occurred more than 15 years out, most of them appeared to be unrelated to melanoma, again suggesting that a substantial minority of these patients may actually have the possibility of doing well in the long run. We've also learned that the node-positive group is quite heterogeneous. Their prognosis may vary based on a number of factors, and the specific factors that appear to be most associated with their prognosis include the number of positive nodes, the tumor burden, in this sense meaning whether the nodes are positive microscopically or whether they're macroscopically positive, that is, whether they're enlarged and palpable. And it's also closely related to whether the primary tumor was ulcerated or non-ulcerated. And so, for example, if a person had a single microscopically positive node and a non-ulcerated primary, their 5-year survival might be as high as about 69%. And on the other hand, if a person has 4 or more positive nodes and they're enlarged and bulky positive nodes and had an ulcerated primary, their 5-year survival might be about 13 or so percent. So it's a very heterogeneous group, and I think we have a better understanding of that now than we did 10 years ago. So the success of the sentinel node ended the elective lymph node controversy, but it did create some other controversies that we're still trying to figure out today. One remaining question is, how broadly should the sentinel node biopsy be applied? And secondly, do all patients who are found to have a microscopically positive node really need a completion lymph node dissection? And I'll spend the rest of the time talking about some aspects of those two problems. First, a few words about the sentinel node procedure in general, just some basics about what we know about it and how we think about it. So the basic idea of the sentinel node biopsy is that it is a staging procedure. That is, we do it to better understand a patient's prognosis. The idea is that if a melanoma is going to spread, it wouldn't go randomly to any nearby lymph node, but it would be likely to spread through existing lymphatic pathways, to spread to one or more primary draining lymph nodes, the sentinel nodes, and today we can selectively identify and selectively remove just those sentinel nodes. If those nodes are free of disease, the other nodes are very likely to be free of disease as well. There are a lot of studies that have been published about the sentinel node biopsy, the single most important of which is the multi-center selective lymphadenectomy trial number 1, the MSLT-1. This was an international multi-center study run by Don Morton, and it took patients who were initially diagnosed with a primary melanoma 1 millimeter or thicker and randomly assigned them to receive either a simple wide local excision alone with ongoing observation of the regional node basin, or to wide excision along with the sentinel node biopsy. Those patients who in that arm were found to be node positive would then go on to receive a completion lymphadenectomy for control of that node basin. The study was designed to look at differences in overall survival in the two randomized groups. And so one thing that the study showed is that sentinel node status is very strongly associated with prognosis. That was confirmatory of what had been reported from a lot of other studies as well. Patients with a negative sentinel node do substantially better than patients with a positive sentinel node. So one thing that we found is it has very good prognostic significance. However, the main objective of the study was to find out whether or not the use of sentinel node biopsy was associated with better overall survival. And in fact, in this study, it was not. However, it was associated with better disease-free survival, almost entirely related to better regional control. Patients who had a positive node went on to have a completion dissection and were subsequently very unlikely to have a regional relapse in that node basin. Another interesting finding was that if you looked at the patients who had simple observation of their regional node basin, over time, they went on to have relapses in that regional node basin to about the same percentage of patients who were found to have positive nodes in the sentinel node biopsy group. Other interesting findings is that among the patients with positive nodes, of the patients who had sentinel node detected metastases and then a completion dissection, they actually had better melanoma-related survival as compared to patients in the observation group who subsequently had clinically detected metastases. Additionally, patients who had a completion dissection in the sentinel node positive group had fewer total positive nodes and a lower chance of having lymphedema related to that dissection as compared to the patients who ended up having a completion dissection for a clinical relapse in the observation group. So there's some suggestion that there may be some benefit to early intervention in the regional node basin, even though the study as a whole did not show an improvement in overall survival. So today, the role of the sentinel node biopsy in melanoma management is primarily as a staging tool. For patients with a primary diagnosis of melanoma, once we know the sentinel node status, this becomes the strongest prognostic factor that we know of and tells us a lot about what to expect for that patient. It will often give us some guidance for treatment decisions. It often guides decisions regarding completion lymphadenectomy and will sometimes make a patient eligible or not eligible for systemic adjuvant therapies. It will also, I think, be important for future entry to clinical trials of future adjuvant therapies. Today, the guidelines are mostly well developed. patients who are a good candidate for a sentinel node biopsy include those with an invasive primary melanoma who are clinically node negative, who have a tumor thickness that is greater than or equal to 1 millimeter, or sometimes for patients with a thin melanoma with certain high-risk features. Today, patients with a positive sentinel node should go on to have a completion node dissection, primarily for regional control, and these general guidelines are endorsed by many organizations, including the National Comprehensive Cancer Network, the AJCC, a variety of Australian associations, and many European countries. So for the rest of the time, we'll talk about just a couple of controversies that remain. One difficult problem is what to do with patients with thin melanoma and whether we can define a subgroup of patients with thin melanoma who might benefit from a sentinel node biopsy. The other controversy is regarding whether every patient with a positive sentinel node actually does require a completion dissection. There's considerable ongoing controversy about both of these points. So first, the problem of thin melanoma. First of all, the good news is that thin melanomas are common. About 70% of newly diagnosed cases of invasive melanoma are under 1 millimeter in thickness. Most of them will have a very good prognosis. Most of them are probably well managed with a simple wide excision alone. However, a small minority of patients with thin melanoma actually do have nodal metastases, and some patients with thin melanoma in the future will eventually recur and die of their disease. Overall, if you look at thin melanoma patients as a group, the chance of having a positive node is probably 5% or less for the entire group. So there's been a lot of emphasis on trying to define a subgroup that might have a greater chance of having a positive sentinel node. Additionally, it remains not entirely well worked out whether or not sentinel node status in patients with thin melanoma has the same prognostic significance that it does in patients with melanoma that's intermediate thickness or thicker. So a number of groups have done retrospective studies to look at the question of whether we can define a subgroup of patients who might benefit from a sentinel node among the thin melanoma patients. And most groups have focused on looking at patients who have a thin melanoma between, say, 0.76 and 1 millimeter in thickness, or towards the higher end of the range. And they've looked at what other features might be associated with a higher chance of having a positive node. And the results have been quite diverse. Some groups have identified Clark's level, some have identified mitotic rate, some have identified sex, young age, lymphovascular invasion. One large retrospective study didn't identify any other features that were associated with the risk of having a positive sentinel node. But if you look at the studies in total, the things that appear to be most strongly associated with the chance of having a positive node among the thin melanoma group are having a thickness that is towards the higher end of the thin group, which kind of makes sense, and also having an elevated mitotic rate. And I think that does fit in with our growing understanding that the mitotic rate is a very strong prognostic feature for patients with primary melanoma. The other features in the end turn out to be somewhat weak or somewhat inconsistent factors, including Clark's level, ulceration, angiolymphatic invasion, age, and sex. And today we focus on really the two stronger factors for the most part. And then there's the question of whether or not the sentinel node status for patients with thin melanoma is associated with outcome. Most institutional series have too few sentinel node positive patients and too short of a follow-up time for analysis. Among a couple of retrospective studies that have been published, there does appear to be an association of having a positive node for patients with thin melanoma and worse disease-free survival, and in one study, worse overall survival. I think those need to be interpreted with some caution as they're relatively small studies and they're based on small numbers of patients. So today, the current recommendations are that the sentinel node biopsy can and should be considered for some patients with thin melanoma, particularly if they have a thickness of among the higher part of that thin group, and also if they have an elevated mitotic rate. We might occasionally consider it for patients with certain other features as well, but we're focused mainly on the thickness and the mitotic rate at this time. So our next problem is whether or not we should do a completion dissection for every patient who has a positive sentinel node. And the question arises because of this. So when we do a sentinel node, the nodes that we remove almost always are normal size and normal consistency. They usually look like an ordinary lymph node. They're generally evaluated with serial sections and immunohistochemistry, and when they're positive nodes, they're often positive in the sense of finding a very small cluster of positive cells, sometimes even for a scattered individual small number of cells. And it's not quite clear to us that there's an overall advantage from doing a dissection in patients with that minute amount of disease. So I think that appropriately has been questioned. Another reason one might want to question that, or one might want to not do a completion dissection if there's no clearly defined benefit, is that the completion lymph node dissection is associated with a higher chance of complications as compared to a sentinel node alone. The sentinel node alone, as compared to completion dissection, is associated with a smaller chance of acute postoperative complications such as wound separation, infection, hematomas, and seromas. But those are all short-term complications. I think the complications that we worry about more are the longer-term complications such as the risk of lymphedema as a result of doing a completion dissection. And if patients are not accruing a benefit from the completion dissection, I think properly we should reconsider whether we should be doing those dissections at all. So before we go on, to pause for a moment to think about what our goals are for doing a completion dissection for node-positive melanoma. So for patients who have a positive sentinel node, one reason to do the completion dissection is to complete a person's staging. That is, to determine if non-sentinel nodes are positive as well. And in most studies, somewhere in the neighborhood of 16 to 20% of patients who have a dissection will have positive non-sentinel nodes. And that certainly better informs us about prognosis for those patients. Another reason, and probably the best reason to consider the completion dissection, is for regional control. Doing a dissection probably truly is associated with far better regional control. Patients in the published studies, patients who have a completion dissection for node-positive melanoma have a regional relapse rate, that is among the sentinel node-positive patients. The regional relapse rate after a completion dissection is probably around 4%. It, however, today is quite unclear if there's a survival benefit from doing a completion dissection. And that's where we've gotten stuck on this. I think that's the main question that we need to answer. So one way of thinking about it is that maybe we should try to find patients who are at elevated risk of having positive non-sentinel nodes if you do the completion dissection. And a number of studies have tried to look at that question as well. The results have been quite inconsistent. Some groups have identified features of the primary tumor that might be associated with the chance of finding other positive non-sentinel nodes. Overall, the bulk of the evidence seems to suggest that it's something about the tumor burden in the sentinel node that's most closely associated with the chance of finding a positive non-sentinel node. But different groups have measured that tumor burden differently, and it's never really been worked out exactly how we ought to be thinking about that. Another way to think about it might be to think about what happens if you don't do a completion dissection. And there's not much data available in the literature specifically for this question, at least as of now. One group that did report on that was to do a retrospective study on 134 patients who were gathered from 16 different centers and had a relatively limited follow-up available. And these were all patients who had a positive sentinel node, but then for some reason did not have a completion dissection. Sometimes it was because of medical reasons, sometimes because the patient declined a dissection, sometimes because of a physician's advice. But for whatever reason they didn't have the dissection. this group looked at their outcomes, and they found that overall their disease-specific survival at 36 months was about 80%. About a little over a third of them had some recurrent disease in their follow-up time. Of those, a regional component to their recurrence was found in about half of the cases. Only about 10% of those patients had a recurrence that appeared to be in that node basin only. And overall, they found that the overall survival among this group of patients was not significantly different than a similar series of patients at Memorial Sloan Kettering who did have a completion dissection. Now, it's a retrospective study subject to a lot of different kinds of bias, but I think if nothing else, it should provide us with more interest in answering the question about what happens if you don't do the dissection, and whether or not we really should be doing a completion dissection for this population. In the EORTC, one way they've looked at it is to look at the amount of disease within the sentinel node and think about how the amount of disease might be associated with outcome. And among the group of patients in their databases, they found that if a patient had a burden of disease that was less than 0.1 millimeters, their overall survival was fairly similar to patients whose node had been read as being negative. Patients with microscopic but slightly greater amounts of disease in the sentinel node had comparatively worse survival. So among the EORTC, they've taken that information and designed the MINI-TUB study, which stands, I believe, for Minimal Tumor Burden. And it is a prospective single-arm registration study, and it is open to patients with very small amounts of disease, which is defined as being either less than 0.1 millimeter in the parenchyma or less than 0.4 millimeters in the subcapsular area. And it's that group of patients who have made a patient-related choice to forego completion dissection. These patients are simply being followed over time. The primary outcome they're looking for is the time to distant disease. And of course, they're looking at various secondary outcomes as well, including regional control and cost effectiveness. Another study that's going to help us better understand the role of completion dissection for patients with positive nodes is the Multicenter Selective Lymphadenectomy Trial Number 2, or MSLT2. This is again run by Don Morton, and it's again a multi-center international trial. And it is for patients who have been found to have a positive sentinel node, and that node can be positive either by H&E, immunohistochemistry, or PCR. Patients who meet the entry criteria would then be randomly assigned to either completion lymph node dissection, as is the standard of care currently, or no further surgery, but serial ultrasound follow-up with the potential for intervention in the future if they have a recurrence within that node basin. And the primary outcome they're looking for is whether or not completion dissection is associated with improved disease-specific survival as compared to simple nodal observation. And of course, they're also looking at secondary outcomes of disease-free survival, overall survival. They're looking at the frequency of in-basin recurrence in patients who don't have a completion dissection, and quality of life measures as well. And I think that'll be a very important study to better inform us about whether we should be doing completion dissections in our patients with positive sentinel nodes. And so in summary then, to get back to our two questions that we're asking today, should patients with a thin melanoma have a sentinel node biopsy? Today I think the answer is sometimes, particularly for patients who have a melanoma between 0.76 and 1 millimeter, and also for patients who appear to have an elevated mitotic rate. Among our second question, should all patients with a positive sentinel node have a completion node dissection? I think today the answer has to be maybe. While today the standard of care is to do the completion dissection, I think we're learning more about that question, and it's possible the answer might change. Today I think it is still quite unclear what outcomes we should expect if we omit the completion node dissection. The MSLT2 study, I think, is the study that is most likely to give us better information about how we should be managing these patients best. Thank you.
Very good. That was really an excellent presentation, Julie. So we're waiting for questions from the audience, and I encourage the audience to send in some questions. You can do that on the box in the lower left-hand side of your screen. In the meantime, let me just ask you a few things. Let's hone in on the sentinel node. You mentioned in the talk that the risks of sentinel node biopsy are very minimal, and the only long-term risk is lymphedema. And I think the risk is less than 1% of serious lymphedema. But patients and physicians still are worried about that risk of lymphedema from a sentinel node biopsy. Mm-hmm. Are there certain patients that are at higher risk than less than 1% that you worry about?
Well, I think it is an important thing to worry about. You know, we perform the sentinel nodes fairly commonly, and although we view it as a procedure that comes with a low risk of complications, there really isn't anything we do that comes with no risk of complications. So in addition to a fairly infrequent occurrence of ordinary postoperative problems like wound infection, bruising and bleeding problems, which are quite uncommon, there are reports of lymphedema related to a sentinel node alone. And if you look at our patients as a whole, I think the anatomic site that has a slightly higher chance of having lymphedema would be a lymph node taken from the groin area as opposed to the axillary area or the neck. Mm-hmm. That is associated with a slightly higher risk of lower extremity lymphedema. It's still quite uncommon in that population. And if you look at node surgery in general, and you think about which patients would we have the highest concern about lymphedema for, the patients for whom I have the highest concern about lymphedema are situations where we're operating on the inguinal area, situations where a patient already has a little bit of lower extremity swelling, sometimes for other medical reasons or pre-existing for some other reason. Additionally, I think we know that the elderly are at higher risk of lymphedema as compared to younger patients. And additionally, patients who are quite a bit overweight, the obese patient is at higher risk as compared to a normal weight person. Very
good. We do have a question from the audience asking, in regards to the MSLT2 trial, is there a special type of ultrasound that's used in that trial?
So the ultrasound for MSLT2 the ultrasound probe itself is not different, but the criteria for which they're supposed to evaluate the node is quite scripted. And so the trial defines certain features of the findings of the node that should raise suspicion. And those include things like the size of the node, the shape of the node, whether the node is preserved with normal architecture, whether there's cortical thickening, whether there's loss of the vascular hilum, whether that's not as well defined on the ultrasound. So there are all those features of the ultrasound that should be associated with some concern about whether there's disease within that node. The ultrasound probe itself is not an unusual ultrasound and nothing specific about it, but I think it's fairly scripted about how the results should be interpreted and specifically what the radiologist should look for.
And just to follow up, and how often are the ultrasounds done in the MSLT2 trial?
So in the initial follow-up, it's done fairly frequently. In fact, it's done every 4 months.
Very good. So I think we just want to be clear that this is specifically as part of the MSLT2 trial. We're not suggesting this is an option for patients outside of a clinical trial to do routine ultrasounds.
I would agree with that.
Okay, now we have another question here. Would you comment on appropriate margins for local excision of thin melanomas versus those greater than 1.25 millimeters in thickness? So we didn't really talk about margins too much. Let's talk about that.
That's okay. We can talk about margins. So there are a lot of studies that I think inform our understanding today pretty well about margins and how we ought to think about them. So for patients with a thin melanoma, at this point in history, I think everybody would agree that we should do a margin with a measured 1 centimeter, and that margin means radially along the skin surface away from the melanoma. So, and that is an appropriate margin for pretty much every patient with a thin melanoma today. The margins are also quite well worked out for patients with melanomas that are 2 millimeters or thicker. They should have an excision margin of 2 centimeters. But as I think the questioner points out, among the patients with melanomas between 1 and 2 millimeters in thickness, you could interpret the literature as supporting either a 1 centimeter or a 2 centimeter margin. And I think most of us look upon that as being an area where we can use either a 1 or a 2 centimeter margin based on a variety of factors. And sometimes we will make the choice between 1 centimeter versus 2 centimeter excision based on some other features. Like, for example, we know that ulceration and an elevated mitotic rate are associated with a higher chance of local recurrence. And so I think most of us would be more inclined to err on the side of doing a 2 centimeter excision for folks who have an elevated mitotic rate or ulceration. Also, if patients' thickness falls more towards the higher end of that 1 to 2 millimeter range, I might be more inclined to do the wider excision. If patients have a melanoma that is just barely over 1 millimeter and it does not have any high-risk features, a 1 centimeter excision I think is actually very well supported by the literature. There's certainly a gray zone in there where the decision-making might be a little bit flexible today.
Okay. So we're jumping around a little bit with our questions from the audience, but it's a good question. We talked about the risks involved with a completion lymph node dissection. So how long after a node dissection is a patient at risk for lymphedema?
Well, it's hard to put an endpoint on that. So for patients who do develop lymphedema, they usually do not develop it immediately after the surgery. It's usually the kind of thing that develops somewhat slowly over a period of months or years. It can be a very slowly progressive process. And then there are patients who don't appear to have any recognizable lymphedema in the first year or two, but might develop it later on. And I'm not aware of any sort of endpoint beyond which patients are no longer at risk for developing lymphedema.
Okay. And in your practice and in the literature, is there anything you can do to minimize the chance of edema or delay it?
That's a difficult question. So I don't think we have any clear answer to that today. I think by routine practice, I think many people would recommend for their patients who've had a completion dissection, particularly of the groin area, that they should get in the habit of elevating their leg at night and when reasonably possible occasionally during the day, just as a routine measure. Many surgeons will prescribe fitted compression garments to be worn for the first several months or even a year or so after the dissection. Whether or not those measures actually change whether or not a patient develops lymphedema, I think is really not well understood.
So do you think putting the compression stocking or glove on immediately after surgery is helpful or not? Are you recommending that to your patients?
Yeah, I personally don't think that makes a difference.
Okay. Very good. And another question from the audience, how soon after the sentinel node evaluation, I guess a positive sentinel node evaluation, should the completion lymph node dissection be done?
Well, for routine practice, I think the completion lymph node dissection should probably be done within the first month or so after the sentinel node that is positive. There may be individual cases where there's some reason to delay. There may be individual cases where other medical issues arise or there's some particular reason to delay. In most patients, there's not a particular reason to not do it within the first month or so. And I think one ought to, just because that completes the patient's staging. You get more information from that dissection, and the patient then is able to have a more complete discussion with the medical oncologist about whether any adjuvant therapies are warranted so that they can go ahead and start those therapies without much delay.
Very good. Now here's a question that regards an issue that comes up fairly frequently. Does a re-excision, I guess a wide excision of a melanoma interfere with the performance of a good sentinel node biopsy?
So in general, we think a sentinel node is best performed at the time of the wide excision. Now, the initial diagnostic biopsy can be either a punch biopsy or an incisional biopsy or even a very narrow excisional biopsy. I think all of those types of initial diagnostic biopsy are just fine. We prefer that the wide excision not be done before the sentinel node. The proper performance of the sentinel node really is dependent on being able to inject the tracer in the skin directly next to the original melanoma site. And if a person has already had a wide excision, the original injection site is therefore gone. The radiologist who's doing the injection for the sentinel node therefore ends up injecting perhaps 2 centimeters or more away from the original site. And it's really unknown if that would drain to the same sentinel nodes that we would have wanted to find, that are the real sentinel nodes. It's really unknown exactly how often that might result in us finding the wrong node. So I think it is preferable to do the sentinel node before the wide excision.
Very good. Great. So staying on the topic of the sentinel node, sometimes we do a sentinel node and we find a positive node in places that SAPI would never have predicted, such as in the epitrochlear area or the popliteal area. What do we do with that? Is there a standard for node dissection in those areas?
Well, there is. So there are descriptions in the literature about describing, what one might call a standard lymph node dissection of, for example, the popliteal fossa or the epitrochlear fossa. Those are uncommon sites of spread, but certainly not unknown sites of spread. It is also quite unknown whether or not patients benefit from us doing that. As discussed in the presentation, we have a lot of uncertainty about whether patients benefit from us doing a standard dissection of the axilla or the groin. And so I think we have similar uncertainty about whether patients might benefit from a formal dissection of less common sites like the popliteal fossa or the epitrochlear area. And I think it becomes a matter of judgment about what to do in that circumstance.
Very good. So a follow-up question. I think we might have answered this, but are there contraindications to performing a sentinel node biopsy in a patient? I guess probably not complete contraindications, but I guess some patients are a little bit higher risk, as you mentioned already.
Yeah, I think there are, occasionally we see someone where we question whether we should be doing a sentinel node biopsy. And I think that often falls into the category of patients who have concurrent medical illnesses that are quite serious, right, who have other severe life-limiting medical problems that are occurring around the same time. Those are patients for whom we might decide not to have a sentinel node.
Just one more question about the complications of the sentinel node. Do you think it's important that the surgeon is experienced doing sentinel nodes? Do you have to do a certain number of them to be good at it and have a minimal complication rate?
A sentinel node is a fairly straightforward procedure, but I think that anything gets better with practice. And I think for any procedure, if you see someone who does that procedure on a regular basis and takes care of those diseases on a regular basis, you're probably going to have a higher quality of decision making, a little bit more clarity about the details of how that gets carried out. So while I think the sentinel node is applied widely today, and I think quite reasonably should be, I think you probably do get a little bit of value added by going to a specialist.
Very good. So let's just switch topics a little bit. I don't think we've talked about in-transit disease, which comes up fairly frequently in our practice. Is there a standard for how to approach those patients surgically, specifically the margins of resection for an in-transit recurrence?
Yeah. So when we see a patient with resectable in-transit disease, our goal is to resect that completely and to a clearly negative margin. There really are no studies to inform us about whether a 1 centimeter margin is better than a 5 millimeter margin for that group of patients, whether 2 centimeters is somehow better. And I think most of us are in the practice of doing an approximately 1 centimeter gross excision around the in-transit lesion. I think that reasonably provides good regional control of that particular site. And also, some patients with an in-transit lesion might be considered for a sentinel node biopsy as part of regional staging. Now, we didn't talk about that before, but in studies that have looked at the question of should you offer a sentinel node for patients who have an in-transit recurrence or even a local recurrence, in studies that have looked at that, when you do a sentinel node in those circumstances, you end up finding a positive node almost half the time. And if you believe that finding that regional disease is meaningful and that you would act on that finding, that is, if it's a patient for whom if they had a positive regional node, you would do a completion dissection as a regional control procedure, then it's probably reasonable to do a sentinel node for those patients.
Very good. Now, here's an important question in this day and age. Is reimbursement ever an issue with a sentinel node biopsy procedure?
It is seldom. You know, there was a time when the sentinel node procedure was new. There was a time when we sometimes had problems with reimbursement. Today, if the sentinel node is being done according to published guidelines or in compliance with published guidelines, we seldom have a problem with reimbursement.
Right. So that's great. I think that's all the time we have. So I would like to thank Merck and Genentech and Prometheus Laboratories for their support of this important educational series. Please remember to complete the quiz at the end of this session to secure your CME credits, and stay tuned for our next session, Targeted Therapy and Melanoma Management with Dr. Kevin Kim. My name is Dr. Sharfman. Thank you for joining us.